We're already running behind a little bit. So now we are going to talk about foreign bodies in the airway and about flexible or rigid scopies. We have Dr. MARC MERVEN, who's going to talk about flexible bronchoscopy and foreign body removal, his experience in South Africa.
Thanks very much again. We can dim the lights in the front if that's all right.
Can we have the lights off in the front, please?
So it's already been alluded to many times, but I'll just reinforce the fact that how important the team is. We're very much just a small part of that bigger team, and this is certainly not an exhaustive list of people that are involved in management of the pediatric airway in general. And we need not only each other's expertise, but we also need each other to sort of cry upon and celebrate with in those often quite stressful and difficult decisions and stressful situations that one faces. At Tygerberg, we're very fortunate to have a very, very hands-on pediatric pulmonology team on whose shoulder I rest a lot of my practice. And they hold a central management in the management of these children with airway problems. They've got a dedicated bronchoscopy list that we join every week. And I was just hearing now the difficulties of some places where to have someone else there you need to pay, whereas for us it's part of the practice. If we are available, we can join without an extra fee from the patient's point of view. So we very much hold hands when we work together and co-manage these patients. And because of their contacts with the general peds and with the pediatric ICU, they make a really very good support for us in ENT. But what I've come to realize is, as much as we appreciate them, they also appreciate us, because they're faced with having to deal with all the other problems, and the airway is one of the problems. And to be there for them is also a real help. So don't underestimate your influence from both sides. And interestingly, that one of the things that our pediatric pulmonologists have taken on is the foreign body of the airway. So they primarily manage them. So I'm grateful to the man whose picture is there, Professor Pierre Gossart, and he's quite well known in the realm of pediatric pulmonology for his work in interventional bronchoscopy. So we'll start with this case.
Okay, deep breath.
That's quite. How often you face these patients? They're quite entertaining to show to your family and friends. So the difference between the two is the one is on inspiration and the other one is on expiration, that they're whistling, and this is them going to sleep in the anesthetic. Oops. And then this is the removal of the foreign body through bronchoscopy. So with a flexible scope, looking into the left main bronchus, and all looks fine. And going down the right side is this piece of plastic. And there's a crocodile forceps that is passed through the suction port of the bronchoscope and grabs on the ledge very nicely and is able to come out relatively easily. And this is what it looks like. And this is the culprit. So you can imagine these kids blowing, and it's all in all the little party packs that they buy at the local shop for nothing, or next to nothing. And this is what happens when they take a big breath in. So what is needed? I mean, you all know, and you've all worked with flexible scopes. Some of them use a fiber, some of them have the camera in the tip, so sort of chip-on-tip camera. And then it really is, I think, essential to also have the rigid bronchoscope armamentarium to use on the side. What's interesting is what size. So they come in all sorts of sizes, these bronchoscopes for the children. And when we're looking at the very small sizes, the problem there is some of them don't have suction ports, and some of them have suction ports that are too small to fit in any of these instruments, flexible instruments that one would use. So the main working one is the 4mm one, which has got a 2mm channel, which allows those instruments to be pushed through. And a 4mm fits pretty much most children, as far as I'm aware, certainly the ones that are old enough to be able to walk around or crawl around to get a foreign body down the airway. And then the instruments that are fed through, the main one that is used is this crocodile forceps that was shown just now, and that's what it looks like. It's got this flexible with the different types of bites to grasp the foreign body. The second most commonly used instrument is this basket, and what it's made of is also at the end of a long flexible instrument, and then as you pull the metal through, then this basket sort of closes up. And what's important is that the foreign body is enveloped by those 4 little fibers, and that the foreign body sits against this little metal tip. So until the foreign body is sitting in that area, it doesn't come out. And then there's other things that have been created. This tripod, apparently quite a nice idea. What it also gets pulled in, and as it gets pulled in, there's those 3 little hooks that's meant to hook onto the foreign body. Unfortunately, our experience with that is not great, so very rarely does this one get used. We don't have experience with that, but I've seen in the literature it being described, the balloon, where the balloon is passed beyond the foreign body, blown up and then pulled out. I know our pediatric surgeons do that for the foreign body of the esophagus. They put a Foley's down the esophagus, blow up the balloon and pull out the coin, for example. And then there's a whole lot of other things that you can pass down those ports, cup forceps, brushes, if you are wanting to take histological specimens. From an anesthetic point of view, the main port of airway that's being used for this is the LMA, and the advantage of the LMA is that it allows a larger bronchoscope to get through while maintaining ventilation. So one is still able to ventilate those patients while the procedure is happening. With just an ET tube, it tends to your larger bronchoscope tends to occlude the tube more easily. But it can also be done through a mask. And this is what I was alluding to when I asked whether they're using those those connections where you can pass your bronchoscope through while carrying on ventilating, and that's how it goes through. Deep anesthetic is always used, and that's to prevent the foreign body from being dislodged as you're coming out through the cords, because if they're light, they suddenly go into laryngospasm and they obstruct the removal of the foreign body. And it also prevents the patient from taking a big breath at any time and sort of aspirating the foreign body further down into the airway. What are the foreign bodies that don't come out with the flexible very easily, and where they'll call us from the beginning to help with rigid bronchoscopy. In the subglottic they'll let us know early if the foreign body is too big to be grasped by these instruments that I've mentioned. When it's friable, it's a bit more tricky. The basket is a bit easier because it goes around it and is able to pull it out without breaking. If the foreign body has been there for a long time, and they've seen up to years of foreign bodies being there, then you've got granulation, bleeding, and secretions, which make it difficult with a flexible. If there's a parenchymal pleural disease, then it's difficult because the anesthetic is very brittle. There's not much time to be spent on it, and then experience. There's a long list of the foreign bodies for the last few years that have been used. You don't have to go into the details. I've put a summary here, but it's a lot of whistles that have been surprisingly removed. And out of the 35 that are listed there, only 4 were rigid were required. So it's a nearly 90% success with a flexible bronchoscope. And the ones that they didn't manage with a flexible, the subglottic, large piece of plastic in the bronchus, 1 out of 4 thumbtack pins, and a peanut. It's a patient that presented with a left total collapse of the left lung, and then going down with the bronchus to have a look. This is what was seen. And this is using that basket to remove it. So as you can see, they managed to get those 5 little basket webs to get around it in order to pull it out. And this is what it was. It was a popcorn corn. There's another patient with a foreign body in also the right bronchus. Again, going through an LMA. Suctioning the secretions around the foreign body, which looks pretty stuck there. This is a 7-year-old who had aspirated this thing, which turned out to be the little roller on a cigarette lighter. 7-year-old with that is a bit scary. So there, that crocodile forceps going in, grasping that little ledge that was able to be hung on to. And as you'll see, unfortunately, that ledge was not very easily graspable because it's metal and it doesn't have a nice ledge to hold on to. So here it kind of gets moved to a bigger airway, and then the basket is being delivered through the channel. What's important is that there's space around the foreign body in order to pass the basket and deploy it to beyond the other side. And as you can see, all 4 have taken, and it's weighing against that little metal tip at the end of the basket, and it comes out very nicely. And there's going through the LMA. Here, the next one was actually a piece of metal stuck in one of the main bronchus as well. And he starts by going in with a crocodile, but it was quite a rusty piece of metal, so as they took a bite of it, it was falling apart a little bit, so they decided to dislodge it just enough in order to create a little bit of a space between the mucosa and the foreign body to again deploy that basket beyond it. And here you can see how, unless those 4 little pieces of wires are going nicely around the foreign body, it doesn't quite come out. So there's a little bit of a wriggling that needs to happen in order to get those little wires in position. And once those wires are in place, then you're able to advance the piece of plastic and to secure your foreign body within the basket to take it out. So the next 2 cases, this one we got called in to deal with. It was a patient that a 9-month-old that was diagnosed with croup, but it didn't quite sound right. And on flexible laryngoscopy, it also didn't look like croup. Here what we're seeing at the bedside, the vocal cords, and it looks like it's as if there's a cut in the mucosa of the subglottis there. And on the lateral X-ray, what we're seeing, patient on high flow, or even Thrive nasal prongs, and if you're following the airway, you can see there's a little bit of soft tissue opacification in the area of the subglottis. And then we took him to theatre for rigid endoscopy, and this is what we found. So just moving, so this was lodged in the subglottis and grasping it with a rigid forceps, and then taking it out. And this is what it was, a thorn. And this is a repeat lateral X-ray after, without that soft tissue opacification. And just a few months later, they had another. This is exactly the same thorn except much smaller, which they were able to take out with a basket. And then this is just an endoscopy at the end to check that there wasn't anything left over beyond the thorn. And it all looks fine. Occasionally it gets done as a hybrid. So there they've passed a rigid bronchoscope through the cords into the airway. And in order to get a bit of a better view, close-up view, he's used a flexible scope. So this is a thumbtack pin that is being visualized and grasped with the crocodile forceps. And pulled out, and the rigid bronch is coming out together with the foreign body and the flexible scope. This was quite innovative way of dealing with a foreign body. So these are the pre-op photos, and one can see that pin very low down in the distal bronchi. It's been there for a while, and with a flexible bronchoscope they couldn't get to it. So what they ended up doing is going in with a flexible scope and a fluoroscopic vision. They went in with a scope and the crocodile forceps, and then under fluoroscopy reached that area where the foreign body was, grasped it, and then pulled it out to the main airway, and then eventually out, which I thought was quite an ingenious way of trying to deal with it. Another ingenious thing that had to happen. This was not dealt with a flexible, but I just thought out of interest I would show this. There's a patient with this spring of a closed peg that was partly in the larynx and partly in the post-cricoid area, and the difficulty with it is that it has these two metal pieces. So if you want to pull the foreign body out, it gets caught by the distal one, and if you want to push it in order to twist it and take it out, it gets caught by the other one. So out of desperation, I had to think what to do next, and I got the sisters to go to the orthopedic ward to get a K-wire cutter, which we then had to go through the oral cavity with this huge instrument and managed to cut it into pieces, and it came out luckily per oral. Yes. So one really has to think out the box when one is faced with it, but you do what you have to do, and I'm sure most of us have stories like this to tell. So I was just trying to think, so what would be the potential advantages of a flexible over a rigid scope? It's a bit less traumatic. It's nice flexible endoscopy that goes through. If you have for some reason a patient that you can't hyperextend, then you can work with the necks not hyperextended. You're able to access more distal airways. And unless you're using a rigid telescope or one of these optic forceps, your visibility in my experience is like a little deep dark hole, and this one brings the light and the image much closer to your target, so that from that point of view it's attractive. The disadvantages are a bit obvious. It's larger instruments, and you can potentially ventilate better through the rigid, and you've got a secure airway through the cords with a rigid bronchoscope. But we'll see what the panel has to say afterwards about this. So success rate for removing depends on location, type of foreign body, duration, operator experience and expertise. In experienced hands, over 90%, up to 90% of foreign bodies can be removed that way. But one needs, I think, the skills of both, or at least have someone who has the skill not too far away to help, and then to think out the box. Thank you.
Thank you, Dr. Mark. I think that talk was the perfect antidote for our postprandial state.